This first slide, I thought it was necessary to put in to, we are aware of this, and we know that cervical cancer, that I was reminded today, is really an infectious disease, but we consider it to be a chronic illness. So we put it among the NCDs, but really and truly we're dealing with an infectious disease. And that might create some of the chaos that we have in managing it and addressing it properly. And you would see there that the black text refers to what we are able to do without considerations of limitations in resources, otherwise explained earlier on in more precise terms. And the gray would be what we would want to do in the presence of all the resources that we would want and have on island. And blue, obviously, are things that are done in the absence of the adequate resources. We thought it was important to have an overview of how we want to address this kind of disease. And the overview included that we wanted patients to be referred to a specialized center where the expertise existed, a gynae oncologist especially, radiotherapy services, the ability to administer chemotherapy, and so on. We also thought it was important to outline in this that delays in treatment would reduce the effectiveness of treatment. And if there were other options for addressing the delays in the interim, that we could apply them. And this you will see throughout the presentation. I'll jump this slide, not necessarily important. In this first slide here, you saw in blue, the sub-Saharan expert had indicated that brachytherapy, which in their context seemed to be more present in their areas than even chemotherapy or external beam radiotherapy. In our reality, external beam radiotherapy is more prevalent and sometimes the absence of brachytherapy. So we opted to eliminate that completely from our guidelines. And I can't show you each sheet that we dealt with in the guidelines. What is not presented here would be things that we had consensus on and we didn't agree to change in any way. So in this one, brachytherapy was removed as part of the process, the pathway into treatment. This slide here, so 4, was to indicate that cisplatin, whilst it is the recommendation in the guidelines in bold black, was not necessarily what everybody had the opportunity to use, whether it was that the patient had kidney failure, whether the patient had difficulty stenting, and other complications that would prevent us from using cisplatin. So the option was to use a platinum-based compound. And there were a number of studies that looked into that particular one, including, as we saw earlier on, in reference to more bulky disease and locally advanced disease, SADI's study from Brazil in 1997. And we also wanted to include that in the absence of brachytherapy, as I had mentioned earlier on, that pelvic radiotherapy and concurrent platinum therapy plus hysterectomy could be an option if brachytherapy were not available in the context of treatment. So that would have been put in blue in the absence of the particular resource. It was very important on this slide, for instance, where we looked at positive adenopathy noted in pelvic nodes or para-aortic nodes. And in blue, it was put that if EBRT or brachytherapy were unavailable, a number of options. We thought it was important to say here that in the event, in blue, we wanted to prioritize if there were a delay to definitive chemotherapy and radiation to consider neoadjuvant chemotherapy. And this was to suggest that we want, in our context, the reality is that a number of islands don't have radiotherapy services on island, so we'd have to refer. And by referring, there would be a delay in the patient getting access to these centers. Now, there are a number of studies, and we looked at the Peruvian study where Valdivieso used carboplatin to substitute for cisplatin. And there's a Korean study of 2013 that looked at cisplatin at 100 milligrams per meter squared. And those could be seen to be acceptable in 2 to 3 cycles prior to receiving chemotherapy. We also saw that the Tata Hospital in India would have published a paper recently that showed patients up to 2B would have been acceptable to administer this kind of chemotherapy and result in adequate outcomes with similar effectiveness and not excess toxicities in this case. And we currently await the Interlace UK trial study to confirm and see what these results will bring us. It was also necessary to say that where it concerned tailored radiotherapy boost, that it was necessary to insist that we use high energy photons greater than 6 MVs rather than any other type of energy for doing this particular type of intervention. I would probably jump this slide. Yes, except to say that it was necessary to outline that in patients who were not previously irradiated, that cervical and vaginal cytology could have been acceptable, but not so if a patient had previously received radiation, owing to the atypia and the kinds of abnormalities that are noted post-radiotherapy. And also that hormone replacement therapy would have been an issue for young patients who were treated for cervical cancer, fertility sparing, and to produce a biopsy as a necessary criteria and an anesthesia examination under anesthesia. This was to show that recurrence here, which was not necessarily available in the other countries, would have been necessary in our context. I would jump this one. And as far as radiology and diagnostics were concerned in the follow-up of patients, we thought that it was necessary to eliminate the necessity for chest X-rays and for IVPs, but to insist in both stage 1 and stage 2 to 4 that the option of pelvic MRIs, which would be available in the context of places like Trinidad and the Bahamas and Jamaica. So those would have been put in black as standard guidelines. And PET-CT to be put in gray, as we expect to have a PET scan in Trinidad soon, Martinique and Jamaica, and certainly the Bahamas expecting to have a PET. So this would be in improved, enhanced resource areas. I would jump this slide. That was just to show. This one is also for resection of recurrent cervical cancer. This is all put in gray as well. Not all centers would do that. So we had it there as a thing that we would look towards in the future. This one also to remove the blue sections here and put it in bold that parametrial boost was necessary, and to remove where resources are limited. Okay, again to remove the last 2 lines of this particular slide. This was to show the discussion that we had for the use of Delgado score versus Sedley score, and we await further information to settle whether we need to consider the Delgado score in this case. The consensus was generally that it was not necessary, and the Sedley score would suffice to determine adjuvant treatment. In this particular slide, the contention was that whether combination chemotherapy was preferred in this condition when there are low resources is not available, and we wanted to put gray for the question of bevacizumab and albumin-bound paclitaxel in the first-line setting, and to remove cisplatin 5-FU, which was an option that's available for low-resource countries. I wanted to end this presentation by saying something that my father would say to me sometimes, and I think it encapsulates what we're here for today and how we approach what we're doing. It says, "I expect to pass through this world but once. Any good thing, therefore, that I can do, or any kindness I can show to any fellow human being, let me do it now. Let me not defer nor neglect it, for I shall not pass this way again." Thank you.